Welcome to the deep dive. Today we're tackling a topic you might not have heard much about, Epulis.
Right, Epulis in pets.
Yeah, mostly in dogs. We'll touch on cats briefly too. And we've pulled info from the American Veterinary Dental College, the AVDC, and also the World Health Organization, the WHO. So, pretty solid sources.
Definitely. And Epulis, it sounds a bit technical, maybe.
A little, yeah.
But, understanding these oral growths, it's actually really important for pet owners. They're surprisingly common.
Exactly. So our goal, our mission for this deep dive is really to break down what they are, the different kinds,
How vets figure them out.
diagnosis, yeah, and how they're treated. We want to give you a really clear, kind of concise picture. Okay, so let's dive in. What exactly is an epulis?
Well, the AVDC, they give a pretty broad definition to start. They basically say epuli, that's the plural, is just any mass or lump you find on the gums.
Okay, so like a catch-all term initially.
Pretty much. If
Yeah.
a vet sees something on the gum line that shouldn't be there, Epulis is a good general label to start with.
Okay.
But when we talk about them in the more, let's say, classical sense, we usually mean non-cancerous growths coming from the tissues around the teeth.
The supporting structures.
Exactly, the periodomal connective tissue stroma. Think of it like the foundation holding the teeth in place. And importantly, these generally don't spread. They're not metastatic.
That's good news, generally. But they can still cause local problems, I imagine.
Oh, absolutely. Local effects can be pretty significant.
Right. So these local gum growths, our sources mention three main kinds.
Yep. The big three are fibromatous epulis, or FE, ossifying epulis, OE, and then acanthomatous epulis, AE.
Okay, FEOEAE. Now, I saw that fibromatous and ossifying FE and OE, they sometimes get grouped together. What's the connection there?
That's a good point. An ossifying epulis, the OE, is really a type of fibromatous epulis.
Ah,
The main difference is that the OE has, well, bone or bone-like stuff mixed into that fibrous tissue.
so it's like an FE that started making hard tissue.
Exactly. Got a step further.
Interesting. And the FE, the fibromatous one, that's compared to something in humans, POF.
Yes, peripheral odontogenic fibroma. Veterinary dental folks consider the canine FE to be basically the same thing as human POF. Microscopically, they look very similar.
Gotcha. Okay, so let's focus on that fibromatous epulis, the FEFEF, for a minute. What's the WHO say it's made of?
So the WHO describes the classic FE as being mostly this connective tissue, kind of like the periodontal ligament tissue. You've got these star-shaped cells, smooth collagen fibers, some blood vessels that look dilated but maybe empty.
Okay, basic structure, but there's more to it sometimes.
Yeah, it's pretty common to find little islands or cords of what we call odontogenic epithelium. That's tissue that normally forms teeth.
Ah, okay, tooth-forming tissue remnants.
Exactly. And you might also see areas of dense material, not many cells in it, that looks a bit like bone or cementum or den parts of a tooth. But the key thing, generally benign, non-cancerous.
Right. Now, you mentioned the WHO, but the sources also talked about a newer way to split that FE category up into focal fibrous hyperplasia and POF.
Yes, this is a really key distinction. Focal fibrous hyperplasia, FFH, that's now thought of more as a reactive thing,
Reactive, meaning?
meaning it's an overgrowth happening because of irritation, not a true tumor itself.
Yeah.
Usually, the culprit is chronic irritation from plaque and calculus, tartar buildup.
Oh, so like the gums getting thick and bumpy from being constantly irritated, like a callus.
That's a great way to think about it.
Yeah.
Microscopically, FFH is dense fibrous tissue, mature cells.
Mm-hmm.
You might see little calcium spots, maybe some more cellular bits.
Crucially.
Crucially, no odontogenic epithelium, none of that tooth-forming stuff. You might see bits of the surface gum trapped inside, and the surface can get sore, inflamed.
Okay, that makes sense. FFH is reactive. So how does the canine FE, the one that's like the human POF, differ from this SFH?
Right, the canine FE, or POF, is seen as a true benign tumor. It's a distinct lump of growing connective tissue cells, but it's usually separated from the surface gum by some normal tissue. And this one often does have that odontogenic epithelium, sometimes woven into a looser connective tissue that's quite vascular, lots of blood vessels.
Ah, so the presence of that tooth-forming tissue is a big clue.
Exactly. And you'll also often find varying amounts of hard stuff, osteoidentinoid, cementum-like material, bone-like or tooth-like bits.
So the epithelium and the hard tissue really separate the true tumor, the FEPOF, from the reactive FFH.
You got it. Now, shall we move to the third type? Acanthomatous epulis, AE, or as it's often called, Canine acanthomatous ameloblastoma, CAA.
Right, CAA. This one sounds quite different. What makes it stand out?
Well, microscopically, it's very distinct. Instead of just fibrous tissue, you see these irregular islands and cords of squamous epithelium, like skin-type cells, actively invading the underlying tissue.
Invading. That sounds more concerning.
It is locally. If you look closely at those islands, the cells at the base line up, like fence posts, palisading, we call it, and the cells might look bubbly inside, vacuolated, and show something called reverse polarization. It's a specific look.
Is there a human equivalent for this one?
Interestingly, no, not a precise one. CAA is pretty unique to dogs in its specific characteristics.
And the sources really stress that this one behaves differently too.
Hugely different. AECA is known for being locally aggressive, infiltrative. It sends these little roots or fingers into the surrounding tissue, especially bone.
Wow. So harder to remove cleanly.
Much harder. Even though the cells themselves might not look super cancerous, not a lot of weird shapes or rapid division, typically it's that pattern of growth, the local invasion, that's the defining feature, and why catching it early is so important.
Makes sense. Early, more aggressive treatment is key for this type. Okay, so we've got the generally benign FEOAAFH types
Yeah.
and this locally aggressive AECA. Who usually gets these? Which animals?
Dogs. By far, dogs are the main species affected. Epulides, the overall, are the fourth most common oral tumor type in dogs. Cats, very rare, almost unheard of.
Interesting. Any specific dog breeds more prone?
Yes, there seems to be a predisposition. Brachycephalic breeds the short-nosed guys like boxers, pugs, bulldogs. They tend to get more oral masses in general, including epulides.
Okay.
And boxers specifically seem to get more the fibromatous type, the FE, or just fibrous changes in the gums.
What about age? Is there a typical age?
The average age across all types is around 7 years old, and generally no strong link to being male or female.
Okay. Now, there was that Fiani study mentioned. Did that give more specific numbers?
It did. Really useful data. They found CAA, the Acanthomatous type, was actually the most common in their study group, about 45%.
Wow, nearly half.
Yeah, though they noted that might be a bit high because it was a referral study, so maybe skewed towards more complex cases.
Oh, okay. Referral bias.
Exactly. They found CAA was most often on the front part of the lower jaw, mandible, about twice as often as the upper jaw. Average age was almost 9 years. And they flagged breeds like Goldens, Akitas, Cocker Spaniels, Shelties as potentially predisposed.
Useful pointers. What about the other types in that study? POF and FFH.
POF, the true fibromatous tumor, was about 31% of their cases. Interestingly, that one was more common on the front of the upper jaw, the maxilla, and slightly more males, average age around 8.5 years.
Okay, so location might give a slight clue.
Maybe. And FFH, the reactive hyperplasia, was about 16% in their study. Again, maybe lower than general practice. Most common on the front lower jaw, average age around 9 years.
So location, breed, age can offer hints, but you really need that biopsy for the final answer. What might an owner actually notice at home?
You know, often, especially early on, maybe nothing obvious. It might just be picked up during a routine vet check, an incidental finding.
Right.
But in more severe cases, or especially with that invasive AC8A, owners might see things like excessive drooling, really bad breath, halitosis, maybe difficulty eating or swallowing.
Dysphagia.
Yep, or even some bloody saliva and discharge from the mouth. And if it's really interfering with eating, maybe weight loss.
And what would the vet see on exam?
Well, the obvious thing is a mass, a growth on the gum. Early on, maybe small, smooth, could be on a little stalk, pedunculated.
Okay.
With ACLA, because it expands and invades bone, you might actually see teeth getting pushed out of alignment.
Oh, wow. Tooth displacement.
Yeah. And if it's big enough, it could even cause facial swelling or make the jaw look uneven, asymmetrical. Sometimes the lymph nodes under the jaw might feel a bit enlarged too.
So a lump is the main sign. When a vet finds one, how do they figure out which type it is, or even if it's something else entirely?
Right, because unfortunately, just looking at it doesn't tell you for sure. There aren't specific known causes or risk factors that pinpoint it. So differential diagnoses are key.
What else could it be? What's on that list?
Well, other benign things like a simple fibroma, a polyp, then other odontogenic tumors, so tumors from tooth tissues, and importantly, malignant oral tumors, cancers.
Like squamous cell carcinoma or melanoma?
Exactly. Plus, sometimes just generalized gum overgrowth, gingival hyperplasia can look lumpy, or even a tooth root abscess.
So lots of possibilities. How do you narrow it down and get the definitive answer?
It really comes down to getting a tissue sample. The gold standard is an excisional biopsy, removing the whole thing if possible and sending it for histopathology, looking at it under the microscope.
And imaging, you mentioned x-rays.
Yes, intraoral radiographs are crucial. They help assess bone involvement.
What do they show for the different types?
For 8CAA, you often see significant bone destruction or expansion, clear signs of invasion. For POF or FEOE, the borders might be less clear, maybe some tooth displacement, but often less dramatic bone loss. Although with OE, you might actually see the bony bits within the mass on the X-ray.
And sometimes a CT scan.
Yeah, especially for CAA. If you really need to map out how far it's invaded before planning surgery, a CT gives much more detail.
What about just sucking out some cells? Cytology?
Generally not very helpful for these, unfortunately. You really need to see the tissue architecture, how the cells are arranged, which requires a proper biopsy, ideally getting down to the bone level. That's also vital to rule out the malignant mimics.
Okay, biopsy and imaging are key. So once you have the diagnosis, what are the treatments?
Treatment really hinges on the type and extent. Diet-wise, sometimes soft food is recommended for a bit, pre or post-op, just to avoid irritating the site.
But surgery is the mainstay.
Generally, yes. For POF, the benign fibromatous one, complete surgical removal with clean margins, say at least a centimeter, is usually curative.
Margins meaning healthy tissue around the tumor.
Exactly. And because it arises from the periodontal ligament, you often need to extract the involved teeth and clean out the sockets really well, curettage. If it's really extensive, maybe a bigger block of tissue needs to come out, an en-bloc resection.
What about the ossifying ones, OE? Does the bone make it harder?
It can, yeah. That bony matrix can make getting clean margins a bit more challenging than with the purely soft tissue ones.
And for the AECAA, the aggressive one, sounds like surgery needs to be more radical.
Absolutely. Because it infiltrates, you need much wider margins aiming for at least 2 centimeters of healthy tissue around it. This often means removing a piece of the jawbone.
A mandibulectomy or maxillectomy?
Precisely. Partial mandibulectomy for the lower jaw, partial maxillectomy for the upper, depending on the location. It sounds drastic, but it's often necessary for a cure.
Are there non-surgical options? What about radiation?
Radiotherapy is actually a very good option for CAA, especially if surgery isn't possible or would be too disfiguring. It can offer good long-term control. The protocols usually involve multiple treatments over several weeks.
And medications? Chemotherapy.
Standard systemic chemo. Generally not very effective for these types of tumors, which are often mesenchymal. Poor response, usually.
Okay.
But there are some reports of using chemo locally, injecting cisplatin directly into the tumor, intralesionally, for palliation. And another drug, blomycin, injected locally, has shown some success specifically for Acanthomatous epuli.
Local chemo, interesting. Any caveats with those?
Oh yeah, chemo drugs have risks, toxicity. It's definitely something that needs expert guidance, usually from a veterinary oncologist if you're not familiar with using them.
Right, specialist territory. So after treatment, what's the follow-up? And what's the outlook, the prognosis?
Good monitoring is key. Regular, thorough oral exams are a must-check the site, the whole mouth, head, neck. And periodic x-rays, especially after CAA removal, to watch for any recurrence.
Makes sense. And prognosis-wise, we know CAA is invasive.
It is.
Yeah.
But the good news is, if you achieve complete surgical excision, meaning the lab confirms the margins are clean, free of tumor cells, the prognosis is generally good for all types.
What about survival times? Any data on that?
There is, though numbers vary between studies. For CAA surgery, one source cited a mean survival of around 43 months, but with a huge range. For OE, maybe around 29 months, and POF, around 47 months mean survival.
And radiation for CA?
Radiation means survival times reported range widely too, maybe 1 month up to over 100 months, with a median around 37 months. One study showed about 85% 1-year survival and 67% 2-year survival after radiation for CAA.
That's pretty good control.
It can be, though there's an interesting, slightly concerning finding. Some reports suggest that a small percentage, maybe up to 20%, of CAA tumors treated with radiation might undergo malignant transformation, becoming cancerous years later.
Wow, really? So the radiation might, in rare cases, trigger a change?
It's a possibility that's been raised. It suggests CAA might have some sort of pre-cancerous potential, perhaps, something to be aware of long term.
Definitely food for thought. Okay, so let's try and summarize the key takeaways from our deep dive today.
Sure. I think the main thing is that epulides are common, especially in dogs. They're not just one thing. You've got different types. Fibromatous, ossifying, acanthomatous.
And those types behave differently.
Exactly. Fibromatous, FEPOF, and ossifying OE are generally benign, less aggressive locally. Acanthomatous, AECAA, is the one known for invading local tissues, particularly bone, even though it rarely spreads elsewhere.
And diagnosis isn't just looking, it needs biopsy, histopathology, and usually imaging like x-rays or CT to know what you're dealing with and plan treatment.
Right. Treatment depends heavily on the type. Surgery is common, aiming for complete removal. Simple excision might work for benign types, but CAA needs much wider margins, often involving jaw resection or radiation therapy is another strong option.
And we really stress the importance of regular vet checkups and dental care.
Absolutely. Catching these things early, when they're small, makes treatment much easier and more likely to be successful. Don't ignore lumps and bumps in the mouth.
This has been super informative. It really clarifies the different kinds of epulides and why a proper diagnosis is so critical. You can't just assume it's benign based on looks.
Precisely. And maybe it leaves us, and you listening, with a final thought to chew on. Given that CAA can be so locally aggressive, and that rare possibility of malignant change exists,
Mm.
what's next? What are the future directions for understanding these? Are there new, maybe non-surgical therapies on the horizon that could target these lesions more effectively, perhaps with fewer side effects or less invasive procedures?
Hmm. Yeah, what advancements could offer even better outcomes for our pets facing these common oral growths? Definitely something to keep an eye on.